Now, the topic today will not be too much of evidence-based because this is a new topic. Everybody is involved more and more, and there are no data to show you. I don't know how this evolves, but I think we have to take the challenge, and this is an interesting topic, actually. It's very rewarding to help these patients who are really in miserable situations often, to help them out, and I will show you that these treatments are very challenging, and the results are not as, let's say, stunning as you can get them when you have a standard procedures, but I think you can improve the situation a lot for these patients, and they're very, very grateful for that. I bring you my best regards from Switzerland. This is my hometown Bern, and this is the beautiful view you can have from Bern. And this is a mountain not that far away, actually only 2 hours. Those are suburbs, like suburbs of New York. This is nothing. I learned that in the States again. This is 2 hours from Bern, the Matterhorn. You have it, of course, in Florida. This is made of, I don't know, wood or so, but this is the real one. And a lot of people coming to Bern for continuing education, they take a chance to see this fantastic mountain or even go there and ski. I mentioned Boston, and you see this has always been my second hometown because I spent 2 years in the late 80s, early 90s, and that was actually the beginning of my career, I would say. And I had a chance to go back in February after the Florida meeting and spent 6 months. Maurice nicely reminded me that my first goal was to write the book, and that's the only thing that was not completed, I have to say. But it was a fantastic sabbatical, the best I have had so far, and the last one, of course. But I can show you that 3 projects we could more or less finish. You see, I was heavily involved with postdoc education, and that helped me to redo all my lectures and spend a lot of time on that one. Lunch and learning sessions, and now actually we have established a lunch and learning session between Bern and Boston through internet, which is very easy. 6 o'clock in Bern is 12 o'clock in Boston, so that will not be too bad. And my postdocs will profit because we just decided to have now a lunch and learn session every Tuesday with my postdocs back in Bern. The other one I'm very proud of, and it's then published. We are in the final introductory chapter on a new issue on Periodontology 2000, celebrating 50 years of osseointegration. It will be a fantastic issue, including a lot of the original people from Sweden, Switzerland, the United States. 16 papers analyzing the state of the art of implant dentistry, open questions, current trends, and it will be published in November. And that was a joint venture with Lars Senneby and Hugo de Bruyn from Belgium and from Sweden. One of our strategies is to share knowledge. So if one of you has an interest to have the PDF of this lecture in high quality, you can have it, because I don't believe in intellectual property when it comes to education. So you can send an email to this continuing education department in Switzerland, and then by Monday or Tuesday you get a download link and can download then the whole lecture. It will not have a lot of references because, as I said, this is more clinical oriented, but for sure you can have a look at the strategic slides, how to tackle these kind of problems. So we are talking about aesthetics, and we have had many, many lectures in that field, mainly with Urs Belzer together. Team approach, I'm a strong believer in team approach. I've never done a single crown on an implant. I just have done all my life, also my academic life now, 32 years, implant surgeries. And this is an implant bone restoration, one of the most beautiful ones. Actually, Mr. Manier, the technician, did the technical work. He was at that time still in Lake of Geneva. He's now in Los Angeles, we know. And when you want to get into this field, you know, this is a challenging topic. Patients have high expectations, and we have often lots of risk factors. smile line, gingival biotype, and of course horizontal and or vertical bone deficiencies, multiple missing teeth, and so on. What we have learned is that you need a correct, precise, three-dimensional implant positioning. And what we also learned is due to the ridge alterations post-extraction, and you cannot stop that as we know, we need to perform a bone augmentation procedure in most cases. When you do immediate placement with an intact facial wall, then you do an internal augmentation. If you go for early or late placement, you need to have a contour augmentation to rebuild a facial wall of sufficient thickness to support pleasing, aesthetically pleasing soft tissues. As it seems to be quite challenging, and these cases document this. We see per year now 5 to 10 patients like this. And they are coming from all over the place, from Bern, suburbs, but Switzerland, and from outside. And I hear that when I go to the conferences and talk to my friends, you see, at the dinner table after the lectures, they all see the same. It's a wave of these kind of disasters. And sometimes it's really stunning to see how this is possible. So you have to understand, probably these colleagues did not really understand the challenge they had, and they have performed really lousy, to put it the least. So I go through a short introduction, and then we talk about the surgical challenges, and then we go into the clinic. Treatment options and case reports. I show you 6 cases in detail, and then wrap it up with some conclusions. And when we start with introduction, then of course we have often disaster cases with single tooth replacement. And I mentioned that many times. I did a lot of lecturing in the last 6 months when I was at Harvard, and got exposed to lots of lectures here again, and was still astonished to see how much here in the States people talk always about papilles. And I say, look, that's not the issue. The issue is the mid-facial recession, because when you see these disasters, they're most often in single tooth replacement. It's a recession is the problem. It's not a 5.5 millimeter shorter papilla. That's not a problem. The problem are these recessions. And you see here single teeth, and all of them have major recessions. And this, of course, is a big problem for these patients. When we have adjacent implants, so 2 implants, then the papilla starts to become an issue, because we all know for many, many years, probably almost 20 now, that was late 90s, we talked about that inter-implant papilla, it's actually not it's not the correct term, it's a scar tissue, soft tissue formation. The inter-implant soft tissue formation is often compromised. And when people do not understand that, then of course, I mean, that's the worst I've seen recently, then this is also a big issue. When we have failures with 3, 4, 5 missing teeth, so multiple implants, not only adjacent, then I learned that the malposition starts to kick in, because often these implants are positioned actually in between 2 potential implant tooth positions. And then, of course, it's often then a combination of various factors, lack of bone, malpositions, blah, blah, blah. And you can imagine that, of course, when you start to treat these kind of cases, then it's getting really complex. And you need a very thorough preoperative analysis to understand the problem. Okay, so when we analyze now, I would say we have about 18 years. So mid-90s, late 90s, we have seen the first cases like this. And when we analyze all these, let's say, clinical experience, then I have to say, and that's in 95% of the cases really correct, these are all iatrogenic. Messed up by colleagues who did not perform the quality needed to satisfy the cases. So we have a lot of improper performance of clinicians, and that can include implant malpositions, the wrong position, Selection of oversized implants. Now, 20 years ago, I would not have blamed because we did not understand the biology. Today, we know. So oversized implants have no indication in the anterior from my point of view. Selection of inappropriate number of implants. That's another big problem. And last but not least, surgical approaches that overstress the healing potential. We know immediate implant placement is a very tricky procedure. If you're using the wrong indication, it can be devastating. And that has caused a lot of these kind of problems. 10 years ago, lately, much, much less. So this is all the reasons why we have, and let's say, lousy performance or poor treatment quality, you could call it. Then sometimes you can also have these kind of cases caused by peri-implant infections, but that is much, much less frequent than the first 5 or 4 reasons of implant problems. In my experience, the malposition is probably the #1 cause of aesthetic failure. And we all know the book of Stewie Frome just came out a second time. And with Stephen Chen, we have again make a contribution about this. You see, it was this time chapter 11. And it's a nice summary of malpositions. You see, as you can see here, etiology, prevention, and treatment. And it's a problem. So, now what are the surgical challenges? The challenges you have, and this is just a case, and I will show you this case. When you take these implants off, and in these kind of situations, there's only one option to treat and help the patient. You have to get rid of the implant, take it out. Then you should not lose additional bone because they have already a lack of bone. And that is a big problem, or there has been a big problem until about 4 or 5 years ago. It has improved a lot. Most important is that you have to maintain the palatal bone volume you have, because that's what you have. And we will come back to that. Second, you have to re-establish keratinized mucosa when it's not there. And many times there is a lack of keratinized mucosa. Okay. Also the challenge, that retreatment of such patients often starts with a really compromised situation. So I would not show these patients, I don't know, pictures of standard cases and say that's where we want to go. You tell them we want to improve as much as possible. And I tell them always we do everything for you to optimize the case, but it will never be excellent. That's just the reality. We have to stop to tell patients that everything is excellent. And that's why I often criticize meetings when people only show the 10% excellent cases and pretend this is what we can get. That's not reality. We have another trend also in this upcoming Peri 2000 issue, and that is the overaging population with implant therapy. And the more we get those, you see, last year at University of Bern, the 70-plus-year-old patients made 22% of our patient pool, 22 already. 10 years before, it was 8%. So there's a huge trend in this direction. And that means these patients not only are medically compromised often, they're also anatomically compromised very often. Okay, so first challenge, how to remove an implant. And of course, the trefines that have been developed and recommended 20 years ago are outdated for many, many years. I think I did 2 cases in the posterior mandible to trefine out an implant, and then when I saw the defect, I said that cannot be the solution because you take so much bone off, and in the maxilla that would eliminate the palatal bone structure right away. So that's no way. Then we did for many years peri-implant osteotomy with burrs, fissure burrs, or with piezo, but that's actually also not really elegant. The real breakthrough came when industry came up with implant removal kits using this reverse torque technique, RTT you could call that. And actually that's extremely elegant. And that gives us a chance to get these implants out very easy without even a flap elevation in most cases. Primarily, I have experience with this kit here. This is from Dr. Anitua from Spain. And I know in the States also this kit has quite some following. And I think certain cases I cannot do here with this BTI kit. Probably this is the real thing to do. That is when the implant in the area of the shoulder is rather thin-walled, then I think this is the better one, because then this implant here, this kit here, is actually then split bursting. The implants happened to me twice. And therefore, I'm going to also organize these Neobiotech. I saw those at Harvard. That would help us. We come back to that. Second one is how to get back to keratinized mucosa. And when we started, we said, yeah, we have 3 options. We can do it during implant removal surgery. So you get rid of the implant and fix the keratinized mucosa. Second one, you can do it when you place a new implant. Or you do it as an independent third surgery. That's also an option. Today, after 15 plus years, I would say most often I can manage to do it here. So that's actually the most elegant. Can be difficult when a case is really extremely infectious. You see, then probably it's not the best idea to put there a graft in. Okay, the soft tissue techniques are the same, what we learned. You see, I always said my teacher was Burton Langer 20 years ago, who taught me everything he has known at that time. In exchange, I gave him some hints on GBR. That's how we had a lot of drinks at the bar with beer, 92, 93, 94. And that's nothing new. Show you 2 cases. One that I thought will be very difficult. This is a patient from India, very wealthy, obviously. He told me when I saw him first time, oh, royal family. You see, then I say, oh, what is that in India? Yeah, my grandfather was a Maharaja. Obviously, tons of money. But twice an implant treatment, and this is the second one, and not very happy. And I also thought, my goodness, what was this colleague thinking? Huh? You see, this is a lateral incisor, and it has one of these really 2, 7 millimeter implants. And then the patient actually was referred to me through a colleague in Boston with a background in India, and said, Danny, can you see that patient? I said, let's see. I told him when we would see on the cone beam an intact palatal wall, then we can retreat. If not, then I think I cannot treat him with my techniques I have. I'm not a maxillofacial surgeon. I can do a lot, but then probably that would have been impossible. Then he came, and then we have seen, yes, there is a palatal wall, so okay, we take it out. I was not sure how much force is necessary, because this is a big implant. Huh? Okay, so I asked Urs to take the crown down to get some soft tissue ingrowth, Burton Langer technique, published 94 for immediate implants. And then about 3 months later, patient came back from India, flying in, and then we removed that implant. And you can see here, I think the next one shows this fantastic mal-axis. This is an axis like crazy. And probably the worst I have seen so far. And then we mounted this BTI, and then I was really very impressed to see that after 5 seconds it was already loose. So that was an easy one. So then you just use the ratchet. The ratchet is very strong and huge leverage. And here you see the relationship. And then what we normally do, we freshen the wound, also the bone inside, so we have some bleeding. And then normally when there is not a lot of keratinized tissue, and here we did not have here any keratinized tissue, then we do a socket grafting to have something in there and then put a full thickness graft on top. And this, of course, this is a mucosa graft from the palate. Today, I always make sure it's about 1 millimeter too large, because resizing, downsizing is easy. So you need very good contacts, but that's, of course, not really. Second one. Here I was not that sure. This is a 14 millimeter Straumann type implant with an excellent surface. And you can see the big problem is, again, the axis. So the axis goes through the facial plate, and you see it resulted in a 3 millimeter, even 4 millimeter mucosal recession. The implant is 7 years in place, and actually the insurance sent a patient to me because a dentist wanted to do a new treatment on that case and spend another, I don't know, it was an insurance for post-trauma. And when you have a look here, you can see they could have done easy job. Correct axis, some contour augmentation, and the patient would have had a great result. So we have done the same. I was just a little bit nervous about this, if that will come out so easy. It was in a master course, so actually I had 60 guys downstairs watching, and I thought, I just hope this whole thing is not going to fracture, because that was a little bit my fear. Earth took the crown off again. We let the soft tissue heal in. Normally you don't get a full healing, but almost, so a little opening is often there, some exudate. You see it sometimes. And then the patient came to this master course. And here you see that's this BTI kit. I really have to say, Anitu has made here an excellent job. He also tells me when I see him, he loves me, that I recommend this. But actually, that really helped us tremendously. And obviously, he's selling lots of these kits. And that's good, because patients will profit. And you see there are now 5 different sizes, and they have to fit hand-tightened in a way that you get a good grip. And then you put the special device on top and the hand ratchet, and then you start to turn counterclockwise. And then, of course, the trick is, you see the internal friction will at one time be stronger than the outside integration. And then you get, and then it's loose. That's how it works. Okay, so now you see, this is the special ratchet, and this has an opening here at 200 Newton centimeter. That shows you how much force you sometimes apply. And you see here that actually after about 20 seconds, it opened up. I continue, and I've realized it turns, but there's nothing happens. I hear a lot of whispering downstairs. I think they're all waiting that I end in a miserable situation. And then all of a sudden, and it's loose. Then you can take it off. As I said, I think 4 times I have had a problem. 2 of them were small diameter implants that fractured off. And 2 of them were these Bronnemark type with this Mickey Mouse design inside that actually made this split burst. What is that implant? Noble, perfect. So was not so perfect to remove it. But I think there the biotech is better, you see, also what I showed, because then you have a different mechanism. Okay. So here we have done the same. We are using here a BIOS collagen, cut it into 4 pieces, so really stuff it in, and then taking from the palate a full thickness graft that fits into that, and then we let it heal, and then 2 to 3 months, I would say, yes. The socket grafting is not here to get fully turned into bone. It's mainly to support the graft. I would hate to have there just a coagulum, because that is not a good basis for this. And you see that it fits in nicely, and then you do the suturing, and then that's 20 minutes of procedure, flapless, which is nice. Okay, now how do we treat then, you see? And we have 3 different treatment options, and it all depends on the anatomic situation. It is actually nothing new. It's like in GBR, when you have an implant placement with a local bone defect. And it goes back to Bob Schenk's paper we have published in '94, where he said bone formation comes from the bony walls. And we know the implant should be inside the bone, the implant surface, otherwise it's getting very tough for the Mother Nature to do it. I mean, I fully agree on that. You see, I always tell people, you see, when you're young, you're enthusiastic, and you do stuff that will never work because Mother Nature is always stronger than we are. And you get punished very quickly. So when we have a 2-wall defect, we can go for simultaneous GBR. If it's a 1-wall defect, expose the implant surface outside the bone, then rebuild the bone, put the implant in second. So it's a staged approach. Of course, we try to do everything simultaneous to eliminate a surgical procedure, but I would not make a compromise when I see there has no chance to get a good healing. Today, we have often smaller diameter implants that helps us sometimes with the 2-wall defect and so on.